So we're carrying on with our review of body cavities. We've looked at the main cavities here that we've seen on that diagram, so hopefully you're already fairly familiar with that. And in this video we're looking at more detail at the thoracic cavity. And in this series of videos we're looking at the main body cavities, but then we find that the body cavities are subdivided into smaller cavities. And this is the case with the thoracic cavity. So if we consider this diagram that we looked at from the front of the thoracic cavity, an anterior view, then we notice that this is the thoracic cavity here, around here. So if you rip out the heart and lungs and the major vessels, you'll be left with this cavity where these things are normally housed. What we have here is the lung fields in blue and the vascular fields in red. So we've got the right lung field there and the left lung field here in blue. Here we have the top part of the mediastinum, the superior mediastinum, which contains the aorta and the superior vena cava and large lymphatics. And this part here is the inferior mediastinum, and this is the pericardial cavity, which contains the heart. Peri means round the outside, of course. So we've got two pleural cavities for each lung, surrounded by pleural membranes, and in these videos we're taking a particular interest in the membranes. And we've got the visceral and we've got the parietal pleural membranes, and the mediastinum is in the middle. But let's look at what we mean by visceral and parietal pleural membranes, and we'll do this by looking at the anatomy of the thoracic cavity. So I've just sketched out some lungs here. Now, if you're going to take these videos seriously, you've got to draw the diagrams yourself. Now, this is in the thoracic cavity here, and the abdominal cavity is below, and these are separated from each other via this large sheet of mostly skeletal muscle called the diaphragm. That is the diaphragm there. And then going up from here we have the chest walls going up here, the wall of the chest. This is mostly made of the ribs and the intercostal muscles, the chest wall, and of course your neck. Hopefully your neck doesn't leak, so that's all sealed. So that's basically the arrangement. So this is the thoracic cavity, the diaphragm inferiorly, and then the ribs and the intercostal muscles forming the wall, sternum at the front, vertebral column at the back. Now, the fascinating thing is here is we know that this main thoracic cavity is subdivided into the pericardial cavity and the pleural cavities. So let's look at how these pleural cavities are formed, and we'll see not only does this compartmentalise the lungs, it also has many vital physiological functions and lots of clinical implications as well. Now the first membrane I'm going to draw on is the visceral pleural membrane. So the visceral pleural membrane. Pleural is to do with the lungs. Pulmonary and pleural both mean to do with the lungs. So the visceral first of all. Now the visceral membranes are in contact with the viscera, and the viscera are the organs inside. So if you wanted to eviscerate me, I hope you wouldn't, but if you did, you'd open my body cavities up, rip out all the organs, my heart, my lungs, my digestive system, and I would be eviscerated. So this is the visceral membrane here next to the viscera. And this surrounds the surface of the lung like this. Surrounds the surface of the lung. And when you have a look at a lung, if you're in a butcher's or something, have a look at a lung, or if you go to a post-mortem, and you find you can't peel this membrane off. It's very well attached. So this is the left visceral pleural membrane. And we have the same arrangement on the right, of course. The right lung is surrounded by the pleural membrane, like this. Now, what happens here is this pleural membrane, it doesn't stop there, it just carries on, and it reflects back on itself, like this. it reflects back on itself, and it goes round the lines the superior surface of the diaphragm, and then it lines the inner surface of the thoracic chest wall like this. So it's lining the inner surface like this. So what we have here is the visceral pleural membrane in blue and the parietal pleural membrane in green. And it's the same on the other side. So it's lining the superior surface of the diaphragm like this, and lining the inside of the thoracic cage all the way around like that. So in blue we have the visceral, in green we have the parietal, and the parietal is on the outside. So think of perimeter, parietal, running around the perimeter, running around the outside. So we have these two pleural membranes. Clinical applications just start springing to mind straight away. I mean, the reason people don't like being stabbed in the chest is not so much the pain from the intercostal muscles, although that's painful of course, but the parietal pleural membrane is very, very rich in nociceptors, the pain receptors. So when people are getting chest drains in, we have to make sure they're well anaesthetised, because this membrane is exquisitely sensitive to pain, the parietal pleural membrane with all its nociceptors. But what we notice now is that we have a gap between the visceral pleural membrane and the parietal pleural membrane. And this gap here is the pleural space, And what we actually notice is that the left lung has got its own membrane system, and the right lung has got its own membrane system as well. The two aren't connected. So there's two separate pleural cavities with their separated visceral and parietal pleural membranes. This is immensely important. Now I've actually drawn a space here between the two membranes, the pleural space. But actually there's no real space here at all. This is just me drawing a very anatomically inaccurate diagram. Because actually the space between the two is a potential space. So in the body we get quite a lot of potential spaces. Now what do we mean by this term potential space? What's a potential space? Well, if we take the relationship between the surface of the lung and the visceral pleural membrane, you can't tear that off. So they're in contact like this, but they're connected together, that they won't come apart. There's not a potential space between them, that they are connected. And it's the same with the parietal pleural membrane and the surface of the diaphragm. There's no space, there's no potential space there, because they're physically adhered to each other. The tissues are intertwined at their junction, and there's no space. But with the pleural space, it's different. With the pleural space, in life there is no space. It's actually filled with a very small amount of serous fluid. Now, serous fluid is mostly water and some protein. And the key thing about serous fluid is it's very lubricating. It makes for nice smooth movement between the two. So actually, if we've got the visceral pleural membrane there in contact with the surface of the lung, the parietal pleural membrane is actually essentially in contact with it, apart from this thinnest layer of serous fluid. There's no space there. There is no space. Now, first of all, let me tell you why this is physiologically important. So if you want to breathe in, the diaphragm's going to move down and the chest wall is going to move up and out. But let's think about this. So if the chest wall moves up and out, then can you see that the parietal pleural membrane is moving with the chest wall? It's moving with the chest wall like that. And between the two pleural membranes, between the visceral and the parietal pleural membranes, there's actually a slight negative pressure, around about 4 millimeters of mercury. So it's sucked. That is, the visceral is sucked onto the parietal like that. They're adhered and sucked. Not adhered, sucked with suction pressure because of this negative pressure. So what this means is that when the parietal pleural membrane moves out the way, then the visceral pleural membrane is sucked onto it. So because it's sucked onto it, what that means is the two will move together like that. And as they move, they're going to move relative to each other like that as well. You're going to get that movement with breathing. And it's the same on the bottom as well, the parietal pleural membrane that's adhered to the surface of the diaphragm. Again, that's going to, when this membrane moves down, this one's sucking onto it, so that's going to move down as well. So we're going to get this kind of movement like that. So the fact that there's no space there is why the lungs can inflate. That's why the lungs can inflate. But the problem is that this potential space in pathological situations can become an actual space, because the parietal pleural membrane and the visceral pleural membrane are not physically stuck to each other, they're just sucked onto each other. So that means if something gets in between the two, like this, then it can separate the two membranes, and the potential space becomes an actual space. And there's quite a few things that can do this. So we mentioned chest trauma. So if you're stabbed in the chest like that, then what that means is that air from in the lung can get into the potential pleural space, and air from the outside world can get into the potential pleural space. And if the air's getting into the potential pleural space, can you see it changes from being a potential pleural space to being an actual pleural space, because there's now air in it. There's now air in it. And this is the condition we call a pneumothorax. A pneumothorax, where there's pneumo means air, as in pneumatic tyre. Thorax, to do with the chest. So obviously there's air in the chest, it's hollow, but the air's supposed to be in your lung alveoli, not in the pleural space. And what that would mean is the lung would collapse in the way. And we'd end up with a small collapsed lung like this. And potentially a huge actual pleural space, because the potential space has been converted into an actual space. Well, it's the same with blood. You can get bleeding. In trauma, you can get bleeding into the pleural space. That would be a hemothorax. Hemo, H-A-E-M-O, heme, to do with blood in the chest. Now, of course, you're supposed to have blood in your chest, but it's supposed to be in the intravascular compartment, in the blood vessels in the heart. So if you've got blood accumulating in here, that's pretty serious, actually. And of course, you can't see the blood leaking onto the floor. You can't see it. It's accumulating inside the thoracic cavity. It's an internal bleed. It's an internal hemorrhage. So you can't see it. So in a traumatized patient, you have to infer its existence by your clinical skills. So is the patient becoming anxious? Are they becoming pale and clammy? Is the pulse becoming fast, weak, and thready? Are they developing cold hands and feet? And eventually, of course, the blood pressure is going to drop as they go into hypovolemic shock. But of course, you're going to spot it well before the shock develops, I hope. But that's the problem. I mean, there's a saying in trauma, blood can be lost onto the floor and four more places. So you can bleed onto the floor, you can see that. But can also be lost into the chest, the abdomen, the pelvis. And what's the fourth one? Chest, abdomen, pelvis. Where else can bleed a lot in trauma? It's the long bones, of course. So you fracture a femur, you can easily lose a litre of blood from a fractured femur. And again, it's internal, you can't see it. Or if there's a malignant tumour a malignant tumour in a lung, for example, if there's a malignant tumour, then that can cause the formation of inflammatory exudate, which can fill up in the pleural space, converting the potential pleural space into an active pleural space if it's water-like fluid. Actually, when you drain these, it's not really that water. I mean, hydro is watery, obviously, but it's actually more an inflammatory exudate. And we do this. People with lung cancer get respiratory distress. You put a drain and you can get a litre or two of this fluid out, and that allows the lung to re-expand and the patients feel a lot better. Of course, for hemothorax and pneumothorax, we need to put in a chest drain in there. Put in a chest drain that will allow the air out, and then what we normally do is we bubble it under some water like this, so the water level would be there, and we let it bubble out. And what that means is the air can get out, but the air can't get back in because the water acts as a valve. That's the principle of the underwater sealed drain. So it's so important to know about this for all sorts of reasons. Or again, in pleurisy, have you ever had pleurisy? I mean, pleurisy is inflammation of the pleural membranes. So you get inflammation of the pleura like this. Can be associated with a pneumonia, or you can get it on its own. Very often bacterial infection. So now the pleural membranes are going to be inflamed. So when these move like this to facilitate the breathing process, as we know, so it needs to move like that. They move relative to each other. So the pleural membranes are moving relative to each other. But now there's an inflamed surface between the two. So when they move relative to each other, inflammation, heat, pain, redness, swelling, loss of function, pain. It's going to be very painful. And we've already said that the parietal pleura particularly is very rich in nociceptors. So pleurisy is an incredibly painful condition. That's why we like to treat these patients probably with antibiotics to kill the infection, to get rid of the inflammation. And also we can give them analgesics because if someone's got a lot of pain when they move their chest, they're going to guard their chest wall. It's not going to move properly, and they're at risk of getting pneumonia in the underlying lung tissues. So very serious. Patients with it say it's being like stabbed with a knife every time you breathe. It sounds like an appalling. I've had a little bit of it, and when you breathe, it's just incredibly painful. But I've seen patients with it much more severe, and they say it's like being stabbed with a knife every time you breathe because the pleural membranes are inflamed. So there we see the pleural membranes. How important it is for all aspects of clinical practice, the pleural membranes, and just how brilliant it is that we're built with separate lungs. They're separate. So if you get pneumonia in that lung, if a lobar pneumonia in that one, hopefully it won't spread to that one. Of course, bronchopneumonia can be in both. But if you get a pneumothorax in this lung, then this lung will remain inflated. And that gives you a lung to breathe with till you get to hospital. I mean, one lung is more than capable of maintaining oxygen saturations for quite some period of time, certainly until you can get medical help to get a collapsed lung re-inflated. So that's the pleural membranes surrounding the lungs. But also very interesting, as we've noted, we've got the pericardial membrane to think about here as well. Now, what we have here, of course, this is where we have the heart in the inferior mediastinal space. Now, you probably know that the heart muscle is a nice thick. It's nice thick muscle, the heart muscle. So here we have the heart muscle, the myocardium, like this. And you probably know that lining the inside Lining the inside here, there's a smooth membrane to let the blood flow through the heart smoothly. So the main heart muscle, as we know, is the myocardium. This nice smooth layer here is the that one is the endocardium. Good. But round about the outside we have the pericardium. Now the thing about the pericardium is it's in layers. So there's layers of pericardium. So what we have first of all is we have a thin layer of pericardium on the outside there, on the outside of the heart. But is the heart one of the visceral organs? Yes, it is. It's part of the visceral organs. So this layer here is the visceral layer of the pericardium. So that one there is the visceral pericardium. And sometimes you'll see this layer also described as the epicardium. The epicardium. Now, epi means on the outside, so it's on the outside of the heart. So it's the epicardium. But you and me know that that's actually the visceral, the visceral pericardium, and it's serous. It's the serous pericardium. And what we mean by this is it secretes serous fluid. So a serous membrane is a membrane which secretes serous fluid, just the same as the pleural membrane. Just remember that important lubricating fluid. So it's secreting this this thin layer of serous fluid there. Very thin layer, but rich in water and protein, so highly lubricating. And then we have like a little gap, and then we have the other layer of the pericardium. And again, these are in contact, anatomically speaking, but we'll draw them with a bit of a physical gap just for the aid of the diagram. So we have that bit on the outside, and if it's on the outside, it's going to be the parietal pericardium. So that there is the parietal. It's also the serous pericardium. It's serous because, again, it's in contact with this serous fluid. So we could just make that layer a bit thicker just to illustrate it. The serous layer between the two. But on the outside, we have a nice thick layer here of pericardium. This is thick, tough, fibrous tissue to protect the heart, and also to stop the heart from overinflating. So that's the fibrous, this bit here is the fibrous pericardium. The fibrous pericardium, this tough bit here. So when we're looking at the heart with a diagram like this one, for example, what we're really looking at here is the fibrous outer pericardium. It's a tough sac. And that protects the heart, but because it's a tough sac, it will only expand so much. So it'll expand to that point, and it's tough fibrous tissue. It won't expand to that point. It won't overexpand. So it prevents overexpansion of the heart, which is good. But then, of course, the downside is that you could potentially get fluid accumulating in between the visceral serous pericardial layers, between the parietal serous pericardium and the visceral serous pericardium. You could get fluid accumulating there. And this does happen in some inflammatory conditions. It can happen in trauma if there's a bleed in the heart, and this will fill up with blood, an immediate life-threatening condition. Because remember that the pericardial sac will only enlarge so much, then it will stop. And that means if there's fluid accumulating within the pericardial sac, and of course this layer here is within the pericardial sac, then can you see that that can only compress the heart inside? Because the heart, if we imagine that this is, imagine that the heart is, imagine that this is the heart here, then the heart is completely surrounded by the pericardial sac like this. And the pericardial sac can only expand so much. So if there's any fluid accumulating here, whether it's inflammatory fluid or blood, then that can generate some expansion of the pericardial sac, but that's tough fibrous tissue, so only so much, then that will stop. So after that it will start compressing the heart. It's a very analogous situation to the one we get in the skull, where if there's a space occupying lesion, for example a subdural hematoma growing in the skull, that can only the skull won't expand, so that's going to compress the brain in the way when the compensatory mechanisms are exhausted. So the heart can get squashed, and of course that's an immediate life-threatening condition called cardiac tamponade. Cardiac tamponade. So important to remember in inflammatory conditions such as pericarditis, and also important to remember in trauma where you can get blood in this potential space. And again, this would be an example where a potential space is converted into an actual space, exactly what we don't want. But physiologically, most of the time, these serous membranes, whether it's the pericardial membrane, when the heart's beating, it's going to move against itself like that, or whether it's the pleural membranes as they move against each other with a suction effect during inhalation and exhalation. Normally it works fine, but normally, of course, they are a potential space. If the potential space becomes an actual space, that is always a pathological situation that you need to learn to recognise and treat. So there we have a review of the thoracic cavity and the associated subcompartments within it, the subcavities within it really, that it's subdivided into the right and left pleural cavity and the pericardial cavity.